Hi, this is Jennifer Yankee doing my health provider interview presentation. My interview that I conducted was regarding the use and perceptions of nurse-driven protocols in different areas of practice. And my PICO question was, how do patients with acute or chronic issues benefit from nurse-driven protocols versus conventional physician management? And I used different areas of practice. I was not able to decide on acute care versus long-term care, for example. So I did sample various health providers from acute care, long-term care, one clinic nurse, and one surgical technologist because they do use nurse-driven protocols in the OR as well. And the majority of my presentation does relate to acute care, specifically critical care, because that is the area that I work in, and 5 of the nurses that I interviewed either work in or have critical care experience. And also critical care does seem to be the area where there are probably more protocols in use just because of the complexity of the patients. So the 5 questions that I used were, what nurse-driven protocols are used in your area of practice? 2, what do you perceive as benefits of protocols in general? 3rd, what patient outcomes do you see as a result of the protocols versus conventional physician management? And 4th, what additional protocols or changes to existing protocols would you like to see for future practice? And finally, how do you think nurse-driven protocols will change the scope of nursing practice? And the workers that I interviewed, just some general demographics. I interviewed 9 total employees. 1 was a licensed practical nurse. 1 was a surgical technician. And then 7 registered nurses. Average length of healthcare experience is 10 years, with a range of experience being 3 years to 27 years. Wished I could have used a new nurse, but it did not work out for me. So at least we have some experience. 2 of the nurses were long-term care employees, 1 clinic nurse, and then 5 acute care employees, 1 operating room employee. Average age of 39. Education levels, 4 associate's degree, 3 bachelor's degrees, and 2 other degrees. They were 1-year degrees. 2 males, 7 females. Protocols that we discussed were insulin infusion. And on my PowerPoint presentation, I indicated the area of practice that these were most used in. Again, most of these being acute and or critical care. Post-falls protocol. This one related mostly to the long-term care nurses. They have certain protocols where if a resident falls, but they don't necessarily feel they need to go to the hospital. For example, they have 15-minute checks, Q1 hour checks, watching for neurological changes indicating a head injury. Electrolytes protocol. Probably a lot of hospital nurses have seen this one in use. Heparin infusion. If you worked cardiac at all, you've seen this one to maintain blood thinning. And this one I'd like to mention in particular because it shocked me. In the PACU that the surgical tech worked in, out in a critical access hospital, they actually have a bradycardia protocol in PACU where if the post-surgical patient's heart rate drops, they will pace the patient. Rather than try atropine or epi, they will pace the patient. Kind of scary. And then they consult the physician. Other protocols, narcotics administration, and that usually includes Narcan in case we give a little too much. Intravenous access protocol, and then the clinic nurse, one of her protocols was outpatient management of hyperlipidemia. Foley catheter removal. This one is a hot button for any of you that work in acute care at this time. Many hospitals are very much focusing on prompt removal of Foley catheters or assessing whether the patients really need the catheter in the first place. And then finally, an intubation protocol, and this was specific to a critical care nurse in a different facility. And then when I asked the healthcare workers what they perceived the benefits of the protocols, early interventioning with worsening conditions. Here's the interesting point. Every single one of them said these protocols were incredibly convenient for the physicians, which, yes, for example, if we're using the insulin protocol, we have to call a doctor every hour on the hour for an insulin change. How long do you think that would last? They said increased nurse autonomy. Interestingly, a couple of them said it gives more time for direct patient interaction for both the nurses and physicians. It saves us time writing orders for every single thing. Reduction of infection rates. Tighter control of blood sugars, blood thinning, and electrolyte balances. Protocols provide for prompt action and documentation. And finally, that the protocols are useful for inexperienced staff. And on this note, a new nurse might not realize or fully understand, be familiar with the normal ranges for, let's say, electrolyte lab values, but it gives them a starting point without having to call the doctor, or they can ask other staff. So when I was a new nurse, I did find the protocols very useful. They gave me direction without making me feel like an idiot. And then asking about perceived outcomes. These kind of go hand in hand with the benefits. Again, better control over electrolytes, blood sugar, management of chronic diseases, early intervention for worsening conditions, or to prevent other issues. Again, reduction in infection rates, with nurses being able to get rid of unnecessary IVs, central lines, Foley catheters, things like that. Then I asked what changes or additional protocols nurses would like to see. Most of them were expansion of current protocols. We really couldn't come up with a lot of new ones. Nurses in general asked for better pain control protocols, more clarity, non-narcotic versus narcotic, ranges of pain medicines. Sometimes we will only get one dose of something where the nurse might like to use a little less, but then of course it comes to the med error if we make that judgment. In the long-term care arena, the nurses do have protocols, but again, they would like to see them expanded, like assessments for urinary tract infections, blood sugar checks, especially in non-diabetics. A lot of times nurses feel like they have to call the doctor to get an order to do a blood sugar check, where they should be able to do it by a protocol and then let the doctor know. Another very specific one was possibility of blood transfusion, albumin protocols, and this of course is in a very specialized area of practice, a CVOR surgery. And then finally, most of the nurses said they would like to see better physician familiarity with protocols. Because if I have found this, if I call a physician regarding an abnormal lab value, they will say, "What does the protocol say?" They don't know. I said, "Well, I don't have the protocol." So yes, I know I would like to see better physician familiarity with protocols. And then questioning, what does this mean for nursing scope of practice? Well, these protocols are nurse-driven, but they, were created by teams that include nurses, physicians, other hospital workers. And with the protocols, the nurses can initiate an intervention, which will, in many cases, benefit the patient immediately, and then let the doctor know instead of the other way around. Protocols could be beneficial with the nursing shortage. It speeds our practice up. Again, rather than having to call a doctor for an order, we have it, we do it, we move on. And then, of course, many studies indicate, and these nurses say, it increases our autonomy, our confidence, and our job satisfaction. And then in some articles that I researched for this presentation, there were 3 studies in particular showing effectiveness and or results of nurse-driven protocols. The first is prompt removal of Foley catheters in the acute care settings. And I won't read off the statistics, the percents and days and this and that, but if you, in looking at my PowerPoint presentation, there was a decrease in the time that an indwelling catheter was, the time it was in actually increased slightly, but the infection rate went down and the percent of patients that it was used in went down. And the target population for this study was any inpatient with an indwelling catheter minus the obstetrics units. And then in my PowerPoint, there is a slide just showing, it's a little algorithm for a nurse catheter removal protocol that the nurse can use to determine if it's ready to come out. Second one, this relates to the clinic nurse, is outpatient management of adults with chronic conditions. And the 3 chronic conditions highlighted in this study were diabetes, hyperlipidemia, and hypertension. And in the 18 studies included in this meta-analysis, all of these chronic conditions showed increases. Some of them were very small, or improvements, I should say. Improvements, and what these studies included were a clinic registered nurse or equivalent who titrated patients' medications by following a protocol. For example, if the A1C was high, they might need to increase the metformin dose or such. Same for hypertension, hyperlipidemia. The third one wasn't so much as results of a protocol, is that it was regarding the development of hypoglycemia protocols in acute and long-term care settings. And it was a study that first examined nurses' knowledge of diabetes, and then the nurses, in conjunction with other hospital staff, including doctors, developed hypoglycemia protocols. And then they actually did a study on the nurses' perception of the protocol, and they found nurses found it easy to use. They feel that it improved patient conditions, and felt that it again increased nurse autonomy in managing their patients. So in conclusion, I found that there are a wide variety of nurse-driven protocols in different areas of practice. The number and complexity of protocols increased in the complexity of the area of practice. For example, in the clinic, there were virtually no protocols for the nurse to use, versus in the critical care area where I work, we have many, many, many protocols. Some patients will have every last one of them going on. And in general, nurses appreciate and utilize these protocols as much as possible. They save time, they streamline our delivery process. And then finally, the documented studies that I outlined show efficacy in nurse-driven protocols, and that can only benefit our patients. My question to you is, if you could only have one nurse-driven protocol to use in your area of practice, which protocol would you choose and why? And if you do answer this question for me, let us know what area of practice that you work in, please. And that is the end of my presentation. Thank you.